on time. Oops, I apologize. There you go. I'm going to do a quick introduction. My name is Francisco Moreno. I'm a professor in the Department of Psychiatry in the Colleges of Medicine in Tucson and Phoenix, and have the honor of serving as one of the principal investigators of the All of Us research program here in Arizona, a large collaboration between the University of Arizona, Banner Health, and a number of important partners around the state. And with me today, the main feature of our presentation will be Dr. Jason Kearns. He's a professor of Department of Pharmacology, Practice, and Science at the University of Arizona, and he's the Director of Scientific Programs. We thought it'd be really fitting to have an opportunity to visit with you today and share with you how an awesome resource like the Precision Medicine Initiative, funded by NIH and the federal government, is actually a tool that can facilitate the mission of shared by most of the audience members of our conference today, that we can actually promote health equity, address health disparities by virtue of taking advantage of this important resource. I had opportunity to introduce the program in 2018 to the audience while we were all meeting on site and very crowded tables, and it was nicely received at the time. I have to say that one of the comments that I remember hearing from the audience is, what is this going to do for health equity? How is advancing precision health, which had been historically and still to this date a bit also, a resource that was primarily used in very specialized academic centers, and that had benefited and had potential to continue benefiting individuals that were not the most disadvantaged and the most underrepresented. So today we're hoping to give you a quick update of how these ideas, these concerns, these principles that have been actually used to inform the design and the practice of the All of Us research program have been overcome, continue to be overcome, and actually facilitate for us to be doing research to learn more about disparities and also start trying to design interventions to promote equity as much as possible. Okay, and there we go. Quickly, I will mention one of my jobs is I serve as leader in the Office of Equity, Diversity, and Inclusion at the University of Arizona Health Sciences. And an important priority for us is to make sure that we are conducting research that addresses the needs of all communities. In Tucson, we're a minority community. Our K through 12 schools around the states are also majority, they're majority Hispanics. The communities around our states are growing increasingly diverse. Those that are facing health inequities are also a very diverse group of folks. And the research that has been done that involves genomic research has been primarily conducted in individuals of European descent. I'll briefly just point you to this picture that shows here the proportion of individuals that are participating in genomic research. And this is the global population and the different makeup of the people in the world. And European descent folks are the ones in the red here. And so you can see that there's a very dramatic overrepresentation, reflecting the countries in which a lot of this research has been done, followed closely by Asian, primarily East Asian. And as you can see, individuals of African descent and Latin American descent, who are communities most underserved, along with American Indian, Alaska Native communities, have not been adequately represented in genetic research, in spite of being a very large proportion of the people in the world. So the All of Us research program is going to help us do something about it. There's a few of the core values. I'll highlight a couple of them. Number one, the name is All of Us. because participation is open to all of us. Right now, we're not inviting people under 18 years of age. That should change in a year or so. But we're inviting people from all walks of life. It's not meant to be a program that has proportional representation of everybody, the diversity of America, but we want to be reflective of the diversity of our country, the diversity of race, ethnicity, and a number of other attributes such as sexual and gender minorities, people that have had lower educational attainment, people that have different income, so that those that are most economically disadvantaged, who often do not participate in these kinds of research, are now going to be invited to participate, and also people that are over the age of 65, and among others. We want to make sure that this is becomes a resource that is made available for researchers also very broadly, including those of you present at this conference, people that are focusing on health disparities research, which has not often been coupled with genomic research. This is exactly what we're trying to promote today. A couple of ways in which this program has prioritized research is by incentivizing the people that are conducting the recruitment to focus on groups underrepresented in biomedical research. I work with our partners in identifying groups in our community that represent the interest of those that are underrepresented in biomedical research. And we are very much fostering those types of partnerships and that will allow us to bring in a more diverse cohort of participants so that we can do research that serves the needs of those communities as well. We're also trying to build a participant-centered design. We are very mindful of the input of members of the community and representatives from community health service agencies that can allow us to share their wisdom and guide ways in which we may best do this. And so we appreciate our local participant engagement boards and our local community advisory committees that really help us address these issues, and the volunteers who themselves serve as ambassadors of this program. Very quickly, I'll tell you a couple of important highlights. This is becoming a very robust program of data already. As you can see, right now we have more than 300,000 individuals who have completed the initial steps of participation. They signed on to the project, they gave approval so that we can have access to their electronic health record data. This is now also increasingly being made available for researchers. And we have also, these individuals have provided biosamples that can allow us to conduct genetic research and look for biomedical biomarkers and things of that nature. This map of the country, as you can see, has some lighter color states and some very dark color states. We're proud that Arizona is the darkest color that you can see in the scale. It says 44,520. It's the number of individuals that have, as of the date of this picture, participated and enrolled as core participants. So they're the Arizona people in the green sphere. So we have contributed a very significant number of participants. So you may be able to really learn a lot about Arizonans if you're able to query this data. We have also significant diversity. This is for the whole country. And you can see that more than 50% of the folks that have participated here are of non-European descent. This is more reflective of the state of the country breakout of demographics. We have more women than men participating, and we're also inclusive in asking individuals to identify their gender as non-binary, transgender, and other options as well. It's a program that is really mindful of the needs of sexual and gender minorities and facilitating a platform for research and advancement in knowledge for this particular area. Again, we have individuals from different age groups. We are very interested in recruiting individuals of advanced age as well. This is what we've done in Arizona so far. As I mentioned, 45,504 that have completed all the different steps. More than 80% of the folks in our states are members of a group identified as underrepresented by medical research. More than half are member of a racial or ethnic group that is also identified as an underrepresented group. And as you can see, we have other types of diversity that really enrich the sample that we have in our state. So how do we facilitate the connection with individuals from all walks of life? Lorian Hansen was talking about how Equality Health really tries to match the providers to the communities that they're serving. We also do the same thing. We're trying to have engagement members and clinical research coordinators that are community congruent, people that speak the language, people that can navigate through the community. And we also involve community health workers, which has been a great model to really bring the knowledge of research, the knowledge of precision medicine to the communities, and be able to provide more awareness and education to the members of our community. These are just some examples and samples of the things that we tend to do. Too much time to go over that, but I did want to mention that this is a continuum of engagement that we're looking at. We're not coming out to recruit people and asking them to sign up as much as promoting that awareness, building the credibility and trust, and utilizing in a number of cases the partnership of agencies that allow us to borrow that trust and endorse the work that we're doing, provided that we have a common mission so that we can build into the partnership with individuals that can be with us going forward. We're hoping they will stay with us for many, many years, providing that rich information that we're hoping will serve you, the researchers, as well. I'm taking quite a bit of time, so I'm gonna just very briefly mention a couple of important things. This is a diagram that Dr. Cecilia Rosales from the College of Public Health in Phoenix and I had an opportunity to design together as ways in which we were trying to roll out our approach. And again, consistent with the continuum of engagement that we had spoken about, we're looking for individuals that we can partner with. We're sustaining, we're fostering those relationships. We're looking at developing that workforce that is going to allow us to address the needs of the community. We want to make sure that we're partnering with those community organizations, that we are addressing their needs, and that we're all supporting the main goal of this program so that we can eventually lead to the participation and engagement of individuals with us. Last but not least, I wanted to say also that participation of American Indian and Alaska Native community members have I'm sorry, I was trying to keep up with some of the chat conversations and got a little distracted, but the All of Us research program has conducted one of the most comprehensive efforts at travel consultation that we have observed to date in an NIH-funded program. And there's much that we have learned in terms of the important needs of the many hundreds of tribes around the states and the couple dozen tribes here in the state of Arizona that are registered. And we continue with a process that will facilitate that this program is conducted in a fashion that is mindful of the needs of the tribes, respectful of data autonomy and the self-determination of the tribes around the country. This is a process that we perhaps came in a bit late as an All of Us research program, since this is a program that got rolled out, and then the process of consultation, which ideally should happen years before this is rolled out, was initiated as the program had already started the recruitment. We will continue to learn from this, but what's also important is that data from American Indian Alaska Natives is at this time not available for research, and there is a process in place that will facilitate the way in which this data may become available, to whom it will be available, what are the safeguards that will be in place, and how we will be managing that relationship, including the management of the biosamples and the use of protected information such as ancestry and things of that nature. So with this, I'm going to pass on the mic to my colleague, Dr. Jason Kearns, so he can tell us a bit more about the research elements of the program and how you can all learn more so that you can perhaps consider contributing in some fashion.
Thanks, Dr. Moreno. As Dr. Moreno had mentioned, I would really like to give a bird's eye view of how this program is built. And so you can see here a summary of the protocol where we're recruiting individuals through a number of different avenues. And after consent and enrollment, the participants consent to share their electronic health records data. They fill out a number of health surveys, and then they go to a visit. And this visit typically, well, the visit includes baseline measurements such as systolic and diastolic blood pressure, and then acquisition of some biospecimens, including urine sample, as well as blood samples. Next slide. And this is how the data look when you access the workbench. And so one of the real nice things about this resource, and one of the things that makes it unique, is we have data coming from all of these different aspects of our participants' lives. So we, of course, we have physical measurements and biospecimens, and we have electronic health records data, which is similar to, I'd say, what other existing resources have. For instance, the UK Biobank has similar resources. But what makes our resource distinct, the All of Us resource distinct, is the diversity, number one. That's a major departure from what these other resources have, but also the use of this survey data. We are able to overlay subjective views from each participant with regard to race and ethnicity, with regard to gender identity, with regard to all of these important considerations that I think previously in biomedical research we just haven't considered. And so we use that data that is patient reported, participant reported, and overlay that against the electronic health records data, so that we can create this rich resource. But all of these different types of data would be available within the resource. Next slide. And this is what it looks like. So this is a screenshot of my participant, the portal. And essentially, each participant has an access, a login where they can go in, they can fill out their surveys. There's a number of additional surveys that get input as time progresses. The first three are the major ones in terms of the basics and the health and lifestyle of each participant. But this is a way to get the participant focused answers rather than just simply relying on the electronic health record to tell us what the environmental conditions are for each participant, what their lifestyle is, what their overall health is. So for instance, there are studies ongoing right now that compare the participant reported family histories with the electronic health record reported family histories, right? And as you may not be surprised, they do diverge in a number of circumstances. And so I think this really underscores the fact that the electronic health record, which was really built for billing and built for money, is not necessarily a quality tool to get participant provided answers, to get the really critical information that we need within such a diverse data set like all of us. Next slide. So to get into a little bit of the nitty gritty, so all of us is unique in a couple of other ways. There are a couple of data access tiers. And really what this is an increasing level of scrutiny and increasing level of security for each tier of data. So the first is public, and this is accessible to everybody on this call right now. You just go to the website, you look at the aggregate statistics, you can see what procedure codes, what ICD-9 and 10 diagnosis codes, what drugs, at least in aggregate, individuals have been prescribed. Then there's the registered tier, which is one level up. And that is really, you have access to row level data for each individual. So survey responses and electronic health records data, but certain things such as smaller race and ethnic groups, such as say, Pacific Islander, if you reported that, wouldn't be available in the registered tier because it provides some privacy risk. Now, the control tier is where that privacy risk is highest, but it's also where the security of the data is highest. So all of those electronic health record, clinical notes, and then the genomic data, which is not technically identifiable information, but could theoretically be used to identify an individual. That genomic data would be available in the controlled tier. Next slide. And this is another unique aspect that increases the security of the resource. If you would advance the slide one more time, Dr. Moreno. So traditionally, in examples such as the UK Biobank, you're downloading all of these participant data. That's not how it works with all of us. The data stays securely on a remote server that you need to be given access to, and you need to go through the approval process and the data use authorization process in order to access this data. And so that improves the security. It enables the coordinating center to know exactly what each researcher is doing at every step. It allows them to prevent things like stigmatizing research or improper identification of individuals. And so this is an increase in security with respect to the All of Us resource. Next slide. If you want to get a good idea of what's available within this data set, this is the best place to go. So this data browser is publicly available. This is in that public tier of data, where you can see the thousands of different conditions, the thousands of different drug exposures and lab measurements. And you can just do a keyword search. You can keyword search for HbA1c or for phenytoin or any other drug, such that you can see how many individuals have been given that drug or given that procedure. You won't be able to get the identifying information for those individuals, and you won't be able to get the row level data for any individuals, but it will at least give you, in terms of feasibility, if you have a research question, can it be answered? Do you have a sufficient number of individuals that have the exposure of interest? And also the survey questions, what proportion of the individuals within this data set have responded that they're of a certain race or a certain ethnicity. Next slide. And this is what it looks like when you go to the registered tier. So when you actually get a access to the actual row level data, it's access to the researcher workbench. And this is how it's facilitated, where you create new workspaces, create new projects, and those get monitored by the Data Resource Center in order to facilitate the results. Next slide. One of the nice things about All of Us is that you can upload your own data, right? So if you wanted to compare rates of race and ethnicity between your data and other data that you have, you can upload the data into the server and actually do statistical analysis comparing your data to All of Us, right? And so there's a number of other tools that you can use. You can use genomic data, which you can upload. You can compare genomes. You can use your own EHR data if you have. And that's one of the nice things about this approach is that even though you can't download the data from All of Us onto your own machine, you can upload the data so that you can actually do statistical comparisons with your own data. Next slide. This is just very briefly a study that we had published earlier this year. And we were looking at race and ethnic discrepancies in terms of anthropomorphic measures such as body mass index, waist circumference, waist to hip ratio. You can see the numbers here. There were 88,000 non-Hispanic whites, almost 41,000 non-Hispanic blacks, 36,000 Hispanics, and about 6,000 Asian participants, which will give you an idea of the breakdown in terms of race and ethnicity. The socio-demographic variables were compared to the NHANES data, which is a survey of the United States in terms of a number of health records. And then you can see here that within the data that we interrogated, there were about 242,000 individuals. This was at the time where we published this paper. And then, there were different subsets of individuals depending on which data we wanted to use. And so the thing about all of us is that, not everybody gave their consent for electronic health records. Not everybody gave their consent for the genomic return of results. And so every piece of data is not available on every single person. So depending on the research question that you would like to ask, you will probably end up excluding a number of individuals because they don't have the data that's relevant to your research question. And that you can see in this flow diagram here. And next slide. With respect to the results, you can see that we had comparable rates of, so this is age-adjusted obesity prevalences across the different race and ethnic groups that closely mirrored what NHANES had found in their surveys. And actually, the All of Us results differed from NHANES just about as much as NHANES differed from itself in different years. And so although we saw statistical differences, this was a very, very well-powered cohort, very large. We saw very similar race and ethnic obesity distributions, suggesting disparities based on race and ethnicity with respect to the prevalence of obesity. Next slide. With respect to genomics, so I'm a genomics person, and I think that the genomics is also one of the major facets of this resource that separates it from other resources. So one of the reasons is that we have participant-provided race and ethnicity, perceptions of their own heritage, but we also have the ancestry, right? And as we know in a health equity conference, that ancestry or the genetics of an individual is often conflated with race, with the self-reported race, with patient and participant perceptions of their origins. And so one of the nice things about this data set is we can start to tease out, the race versus ancestry, and what are the biological contributions to disease, and what are the social contributions to disease. So we can separate sociocultural factors and biological factors, because in prior research, as I think we can appreciate, often it is assumed to be biological, the reasons why race associates with a disease or with a certain outcome, when in reality, this is disparities inherent in our system, in our healthcare system, and how we're recording this data on each individual. But with respect to the genomic plans, there will be whole genome sequencing as well as array genotyping on all 1 million individuals. And there is a return of results. So there's a return of value with respect to these genetic results when it comes to participants. We provide pharmacogenomic data as well as other types of data. Next slide. And then, as Dr. Moreno mentioned, UA Banner is leading the way in terms of the number of core participants from underrepresented backgrounds, as well as the proportion of participants that are contributed nationally. Next slide. And then just to restate the mission about how we focus on community outreach, how we definitely absolutely listen to participants in terms of feedback, in terms of programmatic priorities, and how to do this responsibly such that we're not furthering the disparities that exist in prior research, especially genomic research. And I think that's all I have. Is there another slide, Dr. Marino? Okay, so if you do want to access the researcher workbench, these are the steps. You can see the website over there on the left. You do need an ERA Commons account, although that's changing. It's going to be a login.gov account, but that's not difficult to get. You register, you complete the training, and you sign a data use authorization. So these are relatively simple steps. Next slide. And with that, I'll thank you. I think I ran a little over time, but I appreciate your attention and thank everybody for joining us today.
Thank you so much for both of you for sharing this. And now we can go for Q&A. If people in the audience have questions, they can go and start answering or asking questions, please. Or if you want to type your question, you can do that too, and we'll read it out loud.
And thank you for your questions and your interest. We'll be happy to address any of them. Dr. Kearns, I don't know if you may recall this far, how many studies had been have utilized the All of Us research program to do research? Do we know that?
So, I mean, an exact number I couldn't give you, but I can give you a perspective. So, at least in the U of A community, I think we've published somewhere in the order of 5 studies out of this data. The data were only recently available from a programmatic perspective, though. I think nationally we're somewhere in the order of 20 studies, right? So that'll give you an idea of what proportion of the studies are coming out of U of A specifically versus other sites.
Okay, very cool.
I had a quick question. So you guys mentioned a little bit about, well, obviously race, genetics, sort of how it all entails medically and how the research shows it. So I guess my question is, when it comes to race, and I ask this because I've heard several controversies regarding the answer going back and forth. So would you say race is a risk factor, or it's the SDOHs that are impacted more in certain races? Or what would you say that would be the answer, I guess, would you say race is a risk factor, I guess?
That's an excellent question. And that's exactly what we're hoping to be able to break down a lot more with the efforts of the groups that are developing the participant provided information questionnaires. And so there's a new questionnaire that will be now included as part of the earlier questionnaires that people get. It's for the social determinants of health. We believe that the social determinants of health explain away a lot of the environmental influence on outcomes, on risk factors, and also protective factors. So there's a bit of a continuum with all of those. Race, as we know it, it's a social construct. Having said that, there are genetic differences in the frequencies of certain variants, of certain alleles. And so race sometimes gives us different rates of presence of certain alleles. What has been very interesting now that we have more people participating in research studies is that what is considered a risk allele or a risk gene marker in the European community may not be so in a different group. or it may lose its power as a risk predictor when you have a very heterogeneous population. And then you may also now be able to discover new risk alleles, new risk genes when you look at a more diverse population. So we know that it's going to be difficult to answer. Is race going to be a factor? And it depends on what aspect of race we're trying to address. Most importantly, right now, people talk primarily about the social determinants and the environmental issues that often are reflected in race as opposed to membership to a specific race group. I don't know, Dr. Kearns, if there's something else you'd like to add or correct on that.
Well, I mean, I agree with those statements. I think that, race as a risk factor is, oftentimes, at least historically, it's misinterpreted as a causative risk factor, right? Being an African American increases your risk for obesity, right? And it's interpreted to be a biological association. There's something in the genetics of, for instance, an African American individual that causes them to be more obese. And what we're appreciating as science advances is that, as Dr. Moreno mentioned, there are socio-cultural factors that influence African American individuals more so than they influence individuals of other races and ethnicities. And so it's not necessarily genetic, although that may be a portion of why race associates with a particular disease. And so, you need all of those different kinds of data if you want to try and tease out what the causative factors are for that initial association, right? So, in genetics, we're wising up. We're historically, we would look at an association of race and say, well, there's likely some genetic underpinning for that association, when in reality, we have a growing appreciation for the cultural factors, the socioeconomic factors that play into that, and why it is a risk factor, but not necessarily causative for the disease that we're studying.
Awesome, thank you. Thank you for the great answers.
Thank you, Maria, for that question. I see that we have another question posted in the chat. Thank you, Dr. Ward. I think we have, so you mentioned that gender sexual orientation is being collected. Do we know how robust that data is? So nationally, we have about 10% of individuals that have participated in the All of Us who have identified as members of a sexual or gender minority group. And that's all I can say right now. I am not aware yet of any studies that have been already querying the data and trying to find information specific to these groups. We are really hoping to continue to build a good proportion of individuals that represent this group, so that we can have a more powerful ability to be able to answer the questions of what may be some differences that can be observed. Dr. Kearns?
Yeah, so I agree. I don't know that there have been any rigorous studies looking at this specifically, although I know they're ongoing. Dr. Mitch Lunn at Stanford is working on this. Right now, what we have are the data that are self-reported by each of the participants, right? As for the robustness of the data and the accuracy, I think additional studies need to be conducted, and those are ongoing, but I haven't seen any interim reports or official study results to this point. So I'd say that the answer to that question has yet to be answered.
And again, that very important question, we will have a lot of, when we're all done obtaining information and obtaining also genomic information and additional environmental information, we'll be able to ask a lot of questions, learn a lot about risk factors, health disparities issues, and whatnot. So those would be really cool. It says, what level can the data be drilled down to? Is it dependent on the N? Yes, Dr. Kearns, do you want to address that?
Yeah, so I mean, any individual within this data set, if you have access to the registered tier and not the public available data, you can get, this is the individual. I mean, it's all de-identified data. You can't identify the individual, but you get their study ID, what they answered to each of the participant surveys, and all of their electronic health records data, all on that particular individual. So you can get row level data. You can definitely drill down to a very precise level. Now, your study question and your ability to answer whatever question and hypothesis you have is definitely going to be dependent on the N. It's it will eventually be a 1 million person data set, but there are some scientific questions that can't be answered even with a data set that large. So certainly if you're looking into rare genetic diseases or very rare procedures or populations that have very little representation within the data set, your ability to answer those questions will definitely be dependent on how many individuals there are. But the data browser is a good way to go in and check the feasibility of that approach.
Yes. Well, again, thank you, Dr. Kearns. Thanks to our audience members. We really appreciate you sharing this part of the program with us. Right here, you see the QR code that will allow you to go to the evaluation section. We've been encouraged by the organizers to make sure that we invite you all to do that. And so Dr. Kearns and myself are going to get a lot of money if you give it. No, I'm just kidding. We don't get a kickback or anything like that. But again, do that. I think that will be an important contribution to the meeting for the future planning and optimizing what we're doing together. So again, with that, we will say goodbye to all of you and share appreciation.
Yes,
thank you. Yes, thank you so much for joining. And yes, please complete the evaluation. This, as Dr. Francisco mentioned, will help the organizers to plan for next year's conference. Thank you so much for joining today.
Thank you.